Hello and welcome to today's UPMC video webcast event. As a reminder, during today's virtual event, you may submit questions for our presenter by typing in the Ask a Question box below the video window of your webcast screen and clicking the Submit button. These questions will be answered after today's presentation. It is now my pleasure to introduce today's presenter, Dr. Georgios Zenonos. Please go ahead, sir.
Yeah, it's a great pleasure to be here today. Hopefully this will be a very productive event for everyone. And I am very excited to go ahead with the presentation. Thank you everyone for joining. Again, I'm George Zenonos. I'm one of the neurosurgeons here at the University of Pittsburgh. And I'm the director of the Center for Cranial Nerve Disorders here at the University of Pittsburgh. It's a great pleasure to discuss today about two topics that are near and dear to my heart, but also have a long history here at UPMC, as a lot of the literature on how to treat this diseases actually started here. Dr. Peter Janetta, who was the first chairman at the University of Pittsburgh, introduced a lot of these procedures and taught us how to treat this diseases effectively and safely. So it's a great pleasure to be able to present some of this work and some of this background today. So we're going to go over two processes today. One is trigeminal neuralgia, and the other one is hemifacial spasm. This is really meant to be a presentation for patients. So this is meant to familiarize patients with the disease processes. So in other words, how do I know that I have one or the other, and what causes them? What actually happens for me to be feeling what I'm feeling? How can we treat this? What are my options, and what are the patients to expect, both in the workup when they're discussing their concerns with a physician, or during treatment, and what are the expected outcomes? All of those things are a mystery that hopefully we can shed some light on today. So trigeminal neuralgia, also known as tic-douloureux, it's been said to be the suicide disease. It's really one of the most excruciating pains that anyone can feel. And people did commit suicide quite frequently before we had good ways to treat it. But how do we know that a pain that someone has is actually trigeminal neuralgia? Well, first of all, it has to be in the distribution of what we call the trigeminal nerve. The trigeminal nerve is a nerve that allows us to feel our face. It does have some other functions as well, but the main function that it has is that it allows us to feel our face. It's not the entire head, but the front of the face. It has three parts. It has three branches, and each of them has a different distribution in our face. For example, the first branch, it covers the area that is above our eye. The second branch covers the area between the eye and the mouth. And the third branch covers the area underneath the mouth, mostly the area of the jaw. So the pain has to be in that distribution. The pain that we call trigeminal neuralgia can be secondary to other processes, for example, tumors or tangle of vessels, or multiple sclerosis, which is a disease that affects the sheaths of the nerves. And we also categorize that in what we call the typical or type 1 trigeminal neuralgia, in which the pain is electrical, sharp, almost like a taser kind of pain, and atypical, where the pain is burning, dull. And this distinguishing between these two is extremely important because it dictates how we treat this disease, but it also has implications on what the prognosis is. So the way I like to explain what actually happens, or what we think happens to patients is with an analogy to cables. So nerves are like cables. So if you think of a cable, it has a metal part that conducts the electricity or signal, and has like a little plastic part or a sheath that keeps the electricity separated from the other cables within a bundle. So that way the cables don't short within themselves and they don't confuse the information on their way to the end receiver of information. Same way, a nerve has its axons. The nerve has its axons, which is equivalent to a cable. And it has the coverings of the nerves, what we call the myelin sheath or perineurium, etc. It doesn't matter what they're called, but they have the equivalent structures with a cable. So just like when we were discussing on a phone call, the only way that someone on the other side of the line knows what one person is thinking is what we're articulating and what makes it through the cable. So in the same way, the only way that our brain knows what is going on in our face is based on what information gets to the brain with these cables, with the nerves. So if something tells the brain here that there's somebody stabbing them in the face, that's all they know. That's all the brain knows. There's no other way for the brain to know. So it depends very heavily and exclusively on what information comes through these nerves. So imagine a situation where the cables go bad. So especially the sheaths of the nerves go bad in a way that the cables are shorting. There's electricity from one little bundle going to another bundle, and there's mixing of information. The same thing happens with the nerves. So what happens is that if some of the coverings of the nerves go bad, the electricity within the axon, within the cable, jumps off to the other one. And if that happens, there can be mixing up of information. So also, it's important to know that some of the fibers or some of the neurons that tell our brain that there's pain going on actually don't have their covering. So if there's any of the other ones that give signals, for example, a neuron that tells our brain that somebody is lightly touching us on our face, or that it's cold outside, that information can be confused with pain. And that's why we get that pain back that is confused with the pain fibers. So as we said, many times what happens is that there's a tumor or something else that is actually pushing on our nerve. Imagine that this is what we call the stem or the brain stem, and this is the trigeminal nerve that comes off of it. So if there's anything disrupting it and disrupting this coverage of the nerves, they can be mixing up of information and trigeminal neuralgia or pain. One of the most common things that happens is that there's often an artery that's pushing on the nerve. As we are lucky enough to grow through the years, just like our skin grows a little bit more lax, so do our arteries and many other structures in our body. Every time our heart beats, each artery expands slightly and then comes back to its original size, but not quite 100%. So there's an ever so perceptible change in how much it expands and comes back. So over the years, the arteries get a little longer. Our skull is a closed space, so they have nowhere to go. And in order to accommodate that extra length, they create these loops. So that's why usually trigeminal neuralgia affects people that are over 50. There's about 150,000 or 200,000 people that are diagnosed with trigeminal neuralgia yearly, but it usually affects people that are over a certain age. It can happen earlier as well, just because sometimes there is differences in how we're made, how our arteries are made, and that can cause that sooner. But as a general rule of thumb, happens later in life. So what are we are looking for when we're evaluating trigeminal neuralgia? Well, first of all, is it primary or secondary? Usually, every patient with facial pain that is consistent with trigeminal neuralgia will get some imaging to see if there's a tumor there, if there's a tangle of vessels, or if there are signs there that there's a demyelinating disease such as multiple sclerosis. It's also important to understand the history. Somebody's pain that started immediately after dental work may be related to injury of the nerves around the teeth. Occasionally, there's actual trauma. That somebody was in a car accident and they had fractures in their face, and this caused trigeminal pain. Or there's a reactivation or a herpes infection, etc. So all these things are important to understand what actually caused that. But if there's no other reason, then we say that the trigeminal neuralgia is primary. And that has a different way of treating it. So if you have a tumor, you just remove the tumor. But if you have a primary trigeminal neuralgia, then the way that we treat this is a little different. And that depends, as we're going to discuss a little bit later, whether there's an actual artery pushing on the nerve versus not. Another very important piece of information is to differentiate trigeminal neuralgia into what we call typical or atypical. Now, this differentiation is not 100%, and there's actually an overlap to some extent. There's people and patients that have both kinds of pain. But in general, a typical trigeminal neuralgia has a pain that is sharp. It is more almost like an electrocution pain. If you were to tabulate it over time, it's not continuous pain. It comes in like these little spurts that last a fraction of a second. It can be multiple of them together, but it's not like a building plateau that just comes and stays there. So that's more consistent with what we would call atypical trigeminal neuralgia. Typical trigeminal neuralgia is much easier to treat and is much more amenable to all the procedures that we have to offer. Atypical trigeminal neuralgia is much harder to treat and typically does not respond well to the typical options that we have. Are there any triggers? That is also important. Typical trigeminal neuralgia would have exacerbations of the pain with simple stimuli. Those can be, the air or the wind blowing on someone's face, especially if it's a little cold. It can be brushing your teeth or eating, or even just producing words, talking. That can produce the pain. So that tends to be very restrictive for people because they tend to avoid all the stimuli. And if the stimuli are relevant to eating, swallowing, brushing their teeth, having a shower, that can be extremely disruptive to their life. This pain is the worst pain that anyone felt. So they really remember when they started. Occasionally it can start like as a little twinge, but if you ask people, they will really remember when they started. So a memorable onset is actually very consistent with a typical trigeminal neuralgia. And also important is response to medication. There's a family of medication that affects specific channels on the nerves, specifically voltage-gated sodium channels. It doesn't matter which channel specifically, but what they affect is electrical activity, as opposed to non-steroidal medications that affect inflammation, steroids that affect inflammation, or narcotics and other families of medication that affect pain directly. These medications affect how the nerves get excited. So these are the typical medications: carbamazepine. There's a family of other medications such as carbazepine, gabapentin, pregabalin, and so on and so forth. Now, it's important to know if someone, even just for a little bit, had a good response to these medications. Even if the medication worked and then it stopped working, or if the medication worked for the pain, but it actually produced side effects such as drowsiness, imbalance, and so on and so forth, that required someone to stop taking the medication. But the information about whether they actually responded to the medication initially is extraordinarily important to us, because it actually it portends a very good prognosis about any of the procedures that we do. So knowing that if someone responded to the medication, even just for a little bit, even with side effects, is important. Now, the last very important piece of information is whether there's actually an artery pushing on the nerve. A vein, which is our vessels with a little lower pressure, is less important. And there's a differing on opinions of whether you should go after a vein or an artery. But if there is compression of the nerve by an artery, that changes completely how we treat it. So that's an important piece of information that we need to know ahead of time. And usually by getting a highly specialized sequence of MRI, we can see that. Here you see this MRI depicted here. This line here is our trigeminal nerve on the right side. They're always flipped just to make the doctors think that they know something more. But they're always flipped here. And this little black dot right here, that is actually the artery, and it goes in and out here. It dives down here and comes out here. So we know that this is being pushed here. It's also important where it's pushed. So if it's pushed right at the area where the nerve comes out of the brainstem, that's the most sensitive area of the nerve. That because that sheath or the plastic of the cable, it's the most sensitive area of it. So it's important to know that piece of information. So what are generally the treatment options for trigeminal neuralgia? Again, we always start with medical therapy. If someone, usually this will work, and it has to work for at least a period of time for us to think that someone has typical trigeminal neuralgia. So trying the medication has both a therapeutic, but also has a diagnostic component to it, because if we know that they responded to the medication, it makes us more comfortable that any of the other procedures will actually work. So if someone is doing very well in the medication, they're not having any significant side effects, that perhaps is all that we need to do, and we don't need to do anything further. But typically, over the period of time, what happens is either the medication stops working, or someone has to take increasing doses of those medications that cause significant side effects. So side effects can be drowsiness, it can be imbalance, it can be fogginess, difficulty thinking, difficulty with memory, and proceeding with normal tasks. So if that's in place, then we'll perhaps need to proceed to some of the other options. So perhaps the best option that we have is the microvascular decompression. And we'll show exactly what that is. We showed that artery pushing on the nerve, and the goal of that procedure is to actually take that artery off the nerve so it's not pushing on it. Every time our heart beats and that artery is on the nerve, it pulsates a little bit. And that micro trauma that it causes every time our heart beats, over time causes the coverings of the nerve to go bad, and the confusion of information coming back to the brain. So separating them allows us to actually get to the heart of the problem and address that. Now, many times, however, there's not an artery pushing on the nerve, and we know that ahead of time from our imaging. And in that case, our strategy is a little different. Usually, what we would do there is choose one of the ablative options, and all these options essentially are aiming at causing a very mild damage to the nerve. And the thought process is that by causing this very mild damage, they push the nerve into thinking that it has to regenerate. And by kind of reforming or revamping itself, usually it heals that abnormal connection in a way that the pain goes away. One of the downsides, however, of these ablative options is that they do cause mild damage to it. So when you do this multiple times, there is a risk of causing additive damage to the nerve that can lead to numbness, or what we call neuropathic pain, which is more pain that is dull, burning, continuous pain, which is not pleasant either. and is actually much harder to treat. These options, and we'll talk a little bit more about them, include glycerol rhizotomy, which is an injection of a medication called glycerol. This can be also done with electricity, regular radio frequency ablation, or even a balloon that we float and open up and compresses the nerve. It can also be done surgically with the same approach that we do the microvascular decompression, or it can be done with radiation with what we call radiosurgery. So the microvascular decompression, again called MVD for short, or the Genetta procedure, named after Peter Genetta that we showed in the very beginning in the initial slide. This is perhaps the best option that we have. In order to offer this, there's a few things that have to happen. Firstly, someone has to have typical trigeminal neuralgia. They have to have this lancinating, sharp pain that's almost like a taser. Even if they have a little bit of burning pain, their primary pain has to be typical. So a little bit of burning pain is okay, but if someone is having 95% burning continuous pain and just a very small amount of sharp pain that is not important to them, this is less likely to work. If someone has only typical pain, we see an artery pushing on the nerve, and it's important not just to be in the vicinity, but actually see it pushing on the nerve. If we see all that, the chance that this is going to completely take the pain away effectively and with lasting results, occasionally lasting for someone's lifetime, is over 96%. It's close to 100%. The resolution of the pain is most of the times immediate. Patients wake up without a pain. And over the period of a week, they will be off all their medications that they take for this purpose. Now, over the years, this procedure has been refined significantly. From the time that Dr. Peter Genetta introduced it and populated it, again, it's come a long way. One of the things that we say to people is it has become quite a minimally invasive procedure. So it consists of about a 3-centimeter incision behind the ear, which it's a little bit more than an inch, and then making a little window into the bone to go around the brain. This is not an in the brain surgery, but it gets us access into the skull, but around the brain. Over the years, a lot of things have changed. For example, we've developed a way not to incise the muscle itself, but actually disconnect the muscle and elevate it, but not cut into it. That significantly decreases the pain that someone has postoperatively. By placing the incision exactly where it needs to be with image guidance, and by exposing the maximum that we can right next to two very important veins, we minimize how much we actually disturb the brain because we don't retract it at all, almost at all. We use artificial bone, what we call bone cement, to repair that defect in a way that it looks like it did before, and it significantly decreases the chances for having something like a spinal fluid leakage afterwards. There's no plates, there's no protuberances, there's nothing that actually looks abnormal or foreign. It very much looks like someone's bone. We use absorbable sutures, and again, there's ways to minimize how much stretch that puts on the normal tissues, so it actually doesn't hurt as much afterwards. That all amounts to this being almost an outpatient procedure. We haven't really made it outpatient yet, but it does require people to stay overnight. It does not require them to stay in the ICU, and almost everyone will go home the next morning. There are some complications potentially, but the incidence is very, very low. The chance of having like an infection or a spinal fluid leakage is very close to zero. The chances of having some numbness from the procedure is again very low, especially if you don't manipulate the nerve too much. The chances of having a stroke again is very close to zero. If essentially is very close to zero. there is about a less than a 3% chance of having any changes with hearing on the side that we do the surgery. So in general, it has become a very safe procedure. This is an example of this procedure. This is after we made that opening and going around the nerves. There's these webs that are around the brain, what we call the arachnoid. And this is what we have to divide to actually go and find these nerves. This is our hearing nerve that we're opening right now, and this is the trigeminal nerve. And you see that artery that's around that nerve. By dividing these webs, we make room around it, just so we can put these cushions that are called Teflon patties, and then separate the artery from the nerve. So this is one of the most common ways that we end up doing this. A very small incision is done under the microscope. Occasionally we will use the endoscope, which is a little camera that's mounted on top of a little stick. But this actually requires the incision to be a little larger because it requires more things to go through the incision. Now, if someone doesn't have an artery pushing on the nerve, in that case, we actually don't do an exploration just to see if there's something there. Occasionally, if there's a vein that deforms the nerve significantly, that may be an option, but if there's almost always a vein around the nerve. And by going to disturb the veins, essentially what you're achieving is a very mild damage to the nerve. This can be done without actual incision or opening the skull. Some of the options to achieve this same thing is what we call a glyceryl rhizotomy, a radiofrequency ablation, like we said. Or a balloon rhizotomy. All these three consist of actually putting a needle right next to the angle of the mouth, and then actually with a little opening that exists in the base of the skull that we thread through X-ray, go in that area where all these branches of the trigeminal nerve come together. And again, there are different ways of causing this mild lesion. You can either inject a medication called glycerol, you can use electricity, or you can open up a balloon where it compresses the nerve. They all work the same way, and they all have the same way of getting there. You can actually do a microvascular decompression, although if there's no artery to move away, what you're really doing is actually a surgical rhizotomy. And ways to do that is by separating the fibers of the nerve, or even compressing the nerve. There are different ways to do that. Another way of doing that, especially in people that are very high risk for undergoing any kind of sedation or undergoing any issues with having anything transgress the skin, for example, if they are on anticoagulation. In that way, in those instances, we actually use what we call radiosurgery, which is a very focused beam irradiation. Radiosurgery was popularized at the University of Pittsburgh. There's a huge experience here in treating not only trigeminal neuralgia, but a lot of other conditions. It's important to note, though, that this is not a permanent fix, and usually the pain will come back. Because you're causing a very mild damage to the nerve, it can be additive. You can't repeat that too many times. So usually we refrain to use these options when it's absolutely necessary. So if someone is on medications and they're relatively doing okay, we usually want to delay that if they don't have vascular compression. But they do have vascular compression because that's such a good fix to offer microvascular decompression. There's not a very good reason to wait if someone is struggling with either the pain or the side effects of the medications. And lastly, in patients that don't have typical trigeminal neuralgia or have no component of the trigeminal neuralgia that is typical, the majority of the times, this is much harder to treat. Usually it revolves around medical therapy. Nerve blocks can be tried either with steroid anesthetic medications. A sphenopalatine ganglion block can be tried, or other trigeminal branch blocks. There's other options, such as options that change the function of the nerves, what we call neuromodulation, and that can be peripherally in the spinal cord, something that's done in the motor cortex, or through little wires that go deep in the brain, what we call deep brain stimulation. And in extreme circumstances, sometimes we can divide part of the entire trigeminal nerve. Usually, the lower part of the trigeminal nerve is something that is more amenable to do that. And finally, what we call as a nucleus caudalis DRES procedure, which is lesioning within the brainstem itself. There are other facial pain syndromes. Occipital neuralgia involves pain in the back of the head. Glossopharyngeal neuralgia involves pain in the ear and throat that can have the same qualities as trigeminal neuralgia. And one of the most rare ones is what we call genicular neuralgia, which is this deep stabbing pain in the ear only. So we're going to change gears here and talk a little bit about hemifacial spasm. Hemifacial spasm involves involuntary spasms on one side of the face. It's much rarer than trigeminal neuralgia, and it can be confused with other conditions such as what we call blepharospasm or tics. This can be, it can start very insidiously. It usually starts around the eye in a muscle that's called orbicularis oculi. So it starts around the eye, but over time it can extend to involve most of the face. It can also occasionally be associated with clicking sounds, as it involves one of the little muscles that goes in the ear as well. One of the characteristics is that it's almost universally affecting one side. And then as opposed to someone trying to contract their face voluntarily or having a spasm, the eyebrow moves up, which is something that's called the reverse Babinski sign. It can be caused the majority of times in the same way as trigeminal neuralgia by a vessel that's pushing on the nerve, what we call the facial nerve. That's another nerve that allows us to move our face. So it's important to note that although sometimes people call numbness the inability to move the face, those are two different nerves. The facial nerve moves the face. The trigeminal nerve allows us to feel the face. It can also be done and caused by a tumor, again, a tangle of vessels, or an injury to the nerve, whether that's direct injury or after a viral infection. So again, the majority of the times there's an artery pushing on it. And it's important to know, again, with an MRI, if it's a small artery or a very large artery, because that changes a little bit of what we do. There is a test that's called the lateral spread. Again, there's confusion of information within the nerve itself. So if we give a little stimulus on one of the branches of the nerve, it can, what we call, spread to the other ones. So it can affect the other ones as well. So there's a test that we can confirm the diagnosis with. And we also use during surgery to know that we've done the decompression that we need to do. So again, this is the same premise. There's an artery that's pushing on the nerve. It causes the coverings of the nerves to go bad. And therefore, what happens is even the mild signals that the brain gives to the face to have tone so that the face doesn't droop down, those can be confused with signals to contraction, and then we have the whole face twitching. There's a lot of nerves that run with this bundle. So as opposed to the trigeminal nerve, that is just one nerve running together, the facial nerve runs along with the nerve of hearing, two nerves of equilibrium, and another little nerve that's called the nervus intermedius. It has to do with taste and some other functions, such as lacrimation, tearing, producing saliva. But also it can cause this pain in the ear that's called genicular neuralgia. So genicular neuralgia has to do with this little nerve that's called the nervus intermedius. Some of the treatment options involve actually paralyzing the face artificially. Many people know Botox as a mode of reducing wrinkles. But the way that we reduce wrinkles is by actually paralyzing those muscles. And if you use them strategically, it can keep the nerve from actually reaching the muscle to instruct it to contract. So even though the nerve is telling the muscle to contract, the muscle is not because it's paralyzed. And this can help with some of the symptoms, but typically it is not a great fix because what it produces a weak face that looks like someone had a stroke. If it's used in the exact right amount, this can be less perceptible, but it always is perceptible. What gets to the root of the problem is, again, microvascular decompression. This is very similar to what we described previously. And if there's just a little vessel that's involved, usually that is done with these Teflon patties. But in situations where we have a very large vessel compressing on the nerve, this can be done with something else that we call a sling procedure. This is another example of the sling procedure. So these are here we have a very large vessel that's pushing on the facial nerve. So we pass this little sling. We can use different materials of it, but we pass it around that large vessel, just like when you're mobilizing a trunk. So we use that little loop to pull that artery away from the facial nerve. And we can secure it on the side and then use it almost like a pulley to pull it away. And then we put a little clip to secure it away from it. Now, if there are other little vessels, such as in this situation, we can also use some of those cushions as well. There was actually two vessels here, and there was like a little vessel that was tearing in there, so we used a little cushion, but the large trunk was mobilized away with this sling procedure here. So this is extremely effective, and is usually the only thing that can get to the root of the problem. Again, if you have a tumor or a tangle of vessels, that's what you have to affect first. But if you have primary hemifacial spasm, usually the microvascular decompression is the answer. It's very similar to the trigeminal neuralgia microvascular decompression. Very similar in terms of the size of the incision, the size of the opening in the skull, the size that we repair the tissues. The stay is usually the same. People stay overnight and then they go home. The hearing nerve, as we showed, is at slightly higher risk, but usually that means that you have to be a little bit more patient during the surgery. And at least in our series, it does not necessarily portend a higher risk for hearing loss. So one other difference is that although in trigeminal neuralgia, the symptoms will go away immediately, many times in hemifacial spasm, it requires several weeks to go away. Many times they will get significantly better immediately after the surgery, but for them to be completely resolved, it can take several weeks. Again, we're very lucky to be functioning and caring for patients at a place where it all started. There's more than 22,000 patients that were treated at an institution for a variety of cranial nerve disorders. And over this period of years, a lot of these procedures have been refined to be quite minimally invasive. We have decreased the morbidity and the footprint on the patients significantly, and we've made them a very safe option, a very effective option for patients. The field is keep evolving, and we want to be making things better, but we're very lucky to be able to treat patients here. So thank you everyone for participating. There's my contact information and the link for the cranial nerve disorders webpage. And I think at this point, we'll switch on to see what questions we have and if we're able to answer. I'm going to stop sharing my screen. So we have a number of questions here. So one of the questions by Cindy is, can can the decompression be done more than once? And the answer is yes. The decompression can be done more than one time. It depends on what exactly was done before. Occasionally, the Teflon that is put there, it creates a lot of scar. We do get imaging to see if there's actually something to decompress there. So it can be done again, but the scarring makes the surgery a little bit more challenging and with a little bit more risk just because of the scarring there. However, yes, it can be done before, and we have done this quite a few times. Another question is, if my nerve is wrapped around a vein, can this be fixed? The answer is yes. So when there's a vein pushing on the nerve, the chances that this will work is a little less. But if there's a vein that's really deforming the nerve on imaging, the chance that this will work is much higher. So the highest chances of something working, or the microvascular decompression working, is when you have an artery that's really pushing on the nerve and deforming the nerve. The veins have less pressure within them, but if they're actually deforming the nerve, there's a good chance that that will work as well. So another question is, what is the difference between trigeminal neuralgia pain and neuropathic pain? So neuropathic pain is pain that can involve any nerve, not just the trigeminal nerve. But if we're talking about neuropathic pain within the trigeminal nerve, this is pain that is typically more dull, continuous. It can, even if it's episodic, usually ramps up slowly, stays there, and then goes away slowly. What we call typical trigeminal neuralgia is, again, the pain that we have that is more sharp, lancinating, has this electrical component to it. It almost feels like a lightning bolt. So it's the nature of the pain that differentiates typical trigeminal neuralgia from atypical or neuropathic pain. Does microvascular decompression surgery ever have to be redone if it becomes less effective? I think that's along the lines of what we discussed earlier. Yes, it can be done again. There are more risks because of the scarring, but yes, the answer is it can be done again. I think okay. If you do respond well to carbamazepine, what does that mean? Also, if an MRI was clear. So, very good question. So, if someone does respond very well to carbamazepine, that again builds up a story for typical trigeminal neuralgia. So, typical trigeminal neuralgia will involve at least partial or at least temporary response to a medication such as carbamazepine. So, if someone tells me that I have this typical pain, but I've never actually, that medication did nothing for me, I'll be a little bit more skeptical that any of the procedures that we do will work. Many times you really have to ask more questions, because what people mean is that it either worked for a little bit and then stopped working, or that they took it and then this started having so many side effects that they couldn't be on it for more than a day or two, and therefore they couldn't really tell whether it actually worked for their pain or not. Is medication usually the first line of treatment, or is surgery recommended first? It's an excellent question. So medication is usually the first line of treatment, and as we discussed, it has both a therapeutic but also a diagnostic component. So we want to know if someone is responding to a medication, even as an indication of whether surgery is going to help. Now, if someone has vascular compression and imaging, if there's an artery pushing on the nerve and they're really not happy or they do not wish to be taking medication, then surgery is a very good option, even though there may not be too many issues with the medication. So I'm much more likely to recommend surgery for someone that has vascular compression. And the reason is because if you do microvascular decompression, the effects are quite likely going to be long lasting. Many times they're lasting for the entire someone's life. So it's worthwhile the investment. But if someone is having typical pain, but they don't have anything on the MRI, and it's important to know that we have an MRI that actually shows that. So when we say an MRI is clean, it doesn't mean that they don't have vascular compression. So, but if they truly have had the appropriate sequences and they do not have vascular compression, then I'm a little bit more reluctant to doing one of the lesional procedures, the ablative procedures, because there's only so many times that you can use them and that they usually don't last forever. So you have to be careful when you play those cards because there's only so many of them that you can play. Can typical and atypical both occur simultaneously? Yes. So this is what we would call a type 2A trigeminal neuralgia. So this is trigeminal neuralgia that has both typical and atypical components. There's a difference about whether someone's dull pain comes almost like as a prelude or an aftertaste of the sharp pain. So it's almost like you start having a little dull pain and then have the sharp pain and then have a little dull pain afterwards too. That usually tends to have a more favorable prognosis. But if someone has dull burning pain continuously, irrespective of the sharp pain, sometimes what we tell people is that, you know, if we do something, that's usually going to address the sharp pain and not the dull pain. I've been diagnosed with glossopharyngeal neuralgia. What is the best prescription for that? The carbamazepine 200 makes me so sleepy. Yes, carbamazepine is the prototypical medication, but it does tend to have a little bit more side effects. Pregabalin perhaps is the medication that has the least sleepiness associated with it. Gabapentin is another medication that has a very wide spectrum that can be used. So someone can start with as low as 100 milligrams 3 times a day, but people can take up to 1,800 milligrams a day or so. So there's a very huge spectrum that they can try to find like a happy medium where it takes care of the pain, but not too many side effects. I still have sharp ear pain after a tooth extracted. Migraine medicine helps as well. As C2, I feel pulsations especially. I'm not quite sure what the question is, so we're just going to move to the next one. Is it common to have electrical shock jolts on one side of the head and strong but solid pain on the other side of the face? Usually that's not common, no. So the more of those kind of bilateral symptoms that someone has, both sides, the more atypical the story becomes. Multiple sclerosis, we didn't talk too much about it, but that's the one organic cause that can actually cause bilateral or both sides trigeminal neuralgia. But the more someone has pain on both sides, the less typical trigeminal neuralgia becomes. For atypical trigeminal neuralgia, can a specialized MRI or MRA identify a patient who might benefit from decompression surgery? So if someone has completely atypical trigeminal neuralgia, it's less likely that any surgery is going to work as long as we're talking about a decompression surgery. So it doesn't matter if they have an artery there. It's the symptoms that dictate that they're less likely to respond to that. Can your face become red, swollen, and warm on one side when you have trigeminal neuralgia, occipital neuralgia, and nervous intermediate neuralgia? So typically that's not part of it, but it depends. Yes, that some people do report it, so it can, but it's not typical, a typical component of the trigeminal neuralgia. Can you discuss how Bell's palsy interacts with this, or if it does not? I'm not quite sure what this is. Is it safe to stay on carbamazepine long term? The answer is yes. People have stayed on carbamazepine for a long time. Usually, if there are going to be side effects, is usually earlier. it can cause like low sodiums as well. It can cause some changes, and that can be picked up on a blood test with a CBC for the complete blood count, or liver function tests, etc. But there have been people that have been on carbamazepine for a long, long time. A separate MRI is needed to determine hemifacial spasm. Or would MRI that look at for trigeminal neuralgia be sufficient? Usually the same MRI, as long as they included that same area, which usually they do. This can be either CISS or Fiesta sequences. Any very heavily T2 weighted thin cut MRI image usually would show that. Again, the MRI doesn't make the diagnosis of hemifacial spasm as a clinical diagnosis. We confirm it usually with a neurophysiologic test that's called a lateral spread. So the MRI is only relevant if someone has the appropriate symptoms for it. Can my PCP treat typical trigeminal neuralgia, or do you need to see a specialist? It's completely fine for a primary care physician to order carbamazepine. I think it is useful for patients to have a discussion with a specialist, to have all the options laid out. If they are having, no symptoms and no side effects, it's completely fine to stay on that, and that's what we would do anyway. But if they're uncomfortable with any of the above, they're uncomfortable with the diagnosis, I think seeing a specialist is a very good idea. How come the Teflon pad doesn't bother the nerve, but an artery or vein does? That's an excellent question. I think the key there with the artery, particularly the artery, is that it pulsates. Again, it's not just there, but it's almost like a water hammer effect. So every time your heart beats, that artery expands and then comes back together. And it's that expansion that actually affects the nerve more than anything. Also, again, over time, it becomes more and more, compressive. So over time, the artery again elongates. So it's like a progressive process. It's not a process which is stationary. What treatment options are there when the trigeminal neuralgia branch on 1 or 2 is damaged due to trauma to the face? So if usually these are there's a damage to the first or second branch of the trigeminal nerve, the majority of the times someone would have neuropathic pain. So they're less likely to have what we call typical pain. So if it's more neuropathic pain, this will either revolve around pharmacotherapy or neuromodulation with a stimulator or something along those lines. But it's less likely to respond well to something like a macrovascular decompression. What lifestyle changes would someone need to make after microvascular decompression? Can they resume to normal activities, scuba diving, sports? That's an excellent question, and perhaps something that we should have covered earlier as well. So the answer is that no limitations. The classic evolution of events is someone would go home the following morning. There's a slight limitation in how much weight they would lift for the first couple of weeks. That would be up and around doing most normal activities. They shower immediately after, but we don't want them to doing extreme sports or in extreme temperatures, extreme situations in general. But we do want them to lead like pretty much a normal life. I tell people that I do want them to be off work for something like 10 days, the very least, not because they couldn't go back to work, but they just want to give their body the best chance to heal. And then over the course of the following 4 to 6 weeks, they're essentially completely healed. They can go back to all their activities with no limitations whatsoever. So in general, people are up and around and doing most normal things immediately after the surgery. That's the goal, and that's what we want. I think we're running out of time. Lots of very good questions. We're glad to have done this event, and we have it's been a pleasure to have so many participants as well. So I want to thank everyone for participating. We're always open for questions or consultations, of course. We'll see everyone soon. Thank you.
This concludes today's UPMC video webcast event. Thank you for your participation. You may now disconnect.